Hello, welcome back to TMI Talk with Dr. Mary. I'm your host, Dr. Mary. In this episode, I brought on Dr. Sallie Sarrel to talk about the hidden layers of pelvic pain that often get dismissed, misdiagnosed, or misunderstood. A little bit about Dr. Sallie Sarrel. She is a pelvic floor physical therapist and a person with endometriosis. After it took 23 years of sheer frustration with the medical system, Sallie created a practice to be a safe haven for all people with endometriosis and its associated disorders. Together with Dr. Andrea Vidali, she has founded the Endometriosis Summit to unite surgeons, patients, practitioners, and caregivers to help drive the endometriosis movement forward. She has a passion for treating people with endometriosis that also have leg, bladder, and groin pain. She also gives a voice to all who struggle with endometriosis and adenomyosis. She reminds the endometriosis community that you are worthy and together you can ignite change. So in this episode, we're going to dig into what an occult hernia is and why it's often missed on imaging, why so many people are told their groin pain or endometriosis or just their ovary when it's not, the role of the ilioinguinal and genitofemoral nerves in chronic pelvic pain. We also address why we think something might be a yeast infection when it could actually be nerve compression causing itching in the area, why your feet, fascia, and diaphragm might be contributing to the pelvic floor symptoms or pelvic pain, why misused medical language can negatively affect a patient's healing and their outlook on their prognosis, the role of the thoracic spine in mobility, gait, and lymphatic system, and nervous system regulation, and how it all affects pelvic pain. And finally, that being a pelvic floor physical therapist doesn't necessarily mean we're one-trick ponies and just using internal treatments for the entire session. We have such a vast skill set and the ability to help people with pelvic pain. So even if you're a physical therapist or chiropractor or a movement professional, you can learn a lot from what we're going to be talking about today, because so much of our focus is not on the internal treatments, but more about looking at the person as a whole. So without further ado, we'll jump into this episode. Welcome back to TMI Talk with Dr. Mary, where we dive into non-traditional forms of health that were once labeled as taboo or dismissed as woo. I'm your host, Dr. Mary. I'm an orthopedic and pelvic floor physical therapist who helps health, movement, and rehab professionals integrate whole body healing by blending the nervous system into traditional biomechanics to maximize patient outcomes. I use a non-traditional approach that has helped thousands of people address the deeper roots of health that often get overlooked in conventional Western training. And now we're going to be starting our next episode. Welcome to the show, Sallie. I'm excited to chat with you.
It's so nice to be here. Thank you for having me, Mary.
Even though we were just chatting for 30 minutes before.
Well, who knew? I found a missing piece of me over there in Texas.
Yeah. Oh my gosh. I feel like we could talk for hours, especially with Heather, too. I mean, the three of
Well,
you
Heather's the best.
together. You all are great. Okay, well, we'll just go ahead and jump right in. And yeah, so from your clinical lens, what patterns or patient presentations make you consider an occult hernia, even if imaging comes back clear?
The biggest pet peeve I have in anyone with pelvic pain or endometriosis is when they take their finger and they point to their pelvis where they think their ovary is. And it isn't really their ovary. And then because they think it's their ovary, they go to the gynecologist, and the gynecologist has no idea what a nerve or what a vein or what fascia is, and goes, must be your ovary. I don't see a cyst, so we'll just take out the ovary. And to me, that is a frustrating situation because there is a series of nerves there, but the biggest nerve in particular is the ilioinguinal nerve. And that is going to cause that lower quadrant pelvic pain that radiates sometimes into your pubic bone, which means it's accessing a different nerve, the genital branch of the genital femoral nerve, and then down into your leg and thigh. And sometimes even you'll get some pain into the inside of your knee. And those are presentations, in my opinion, that should be looked into for occult hernia. And what is occult hernia? Is that your next question, Mary?
Yes, explain to everybody what an occult hernia is.
I really changed the name to hidden hernia, but an occult hernia is not necessarily a full blown hole through the peritoneum like a normal, everyday, more common hernia is. It is more likely to be a compression of fat, not fat like your fat, but fat that is native to the body that's found in sometimes what's the preperitoneal space or found sometimes in the inguinal canal. And it's laying against this nerve, really creating pain along the nerves, the ilioinguinal nerve, and often the genital branch of the genitofemoral nerve. And that particular type of hernia is not often spotted on MRI or CAT scan because more often than not, the radiologist is trained to look for the full blown hole and is not necessarily looking for the fat compression to the nerve. And so what happens is people will do things like, I had the ovary out and I still have the pain. Yeah. And now you don't have an ovary and you could go into menopause early, and early menopause is connected with things like Alzheimer's and stroke and heart disease. So I wish we had treated the real cause of the problem. Or they'll say that they have this pain and nothing has helped it, and yet scans are negative. And some people will even say that they've had laparoscopy for endometriosis and nobody saw anything, be it endometriosis or a hernia, and that's because the hernia is not viewable at the same time typically unless you are specifically looking in this area of the body as when you do the endometriosis surgery.
So, what would be the typical way for them to diagnose it?
It is very possible to see a hidden hernia on MRI or CAT scan if you're reading it right. Now, here becomes the problem. I really only trust two people in the United States to read them. Luckily, both of these people do virtual reads. And I think the other problem is that not everyone will operate on them either. So that's why I send people to specialists. Actually, I would say there's three specialists that I would send to, but like think of how many people are in the US that have this pain. Think of how many people you talk to on a daily basis that go, my ovary hurts. And really, we're not paying enough attention to the nerve that lays in the space that people think is their ovary. Now, will the hernia hurt during menstruation and during ovulation? You betcha, because there's inflammation in the area. So people will go, oh, when I ovulate, it's terrible, must be a cyst, must be endometriosis. No, you very much can have dysfunction to this nerve that hurts during ovulation and that hurts during menstruation that is not related to either ovulation or menstruation.
But even like from a physical therapy perspective or rehab perspective, I mean, genitofemoral, and then in that area, you're going to get referral from like T12 to L2. Say somebody doesn't want to have surgery, or maybe they don't have access to the people that you're talking about. We're both PTs, so you would,
Right.
right? Like, what are you thinking from that standpoint?
I start with the spine, just like
Yep.
because we established on the part of the phone call that wasn't recorded that we somehow belong together in this world. So, but I start with the spine and I think about where do these nerves originate, right? And so if you can, of course, you can look at T12 really to about L4 to cover both the genital branch of the genitofemoral nerve, but also to cover the ilioinguinal nerve. And then I think because the ilioinguinal nerve wraps around, there's a lot of myofascial work that can be done on the external and internal obliques. and on, in some ways, range of motion itself in rotation. But here's my other issue, and I have seen techniques to floss those nerves, and basically you look at the way the nerve runs. You can open any anatomy book that you have and you move the person in the direction of the nerves, and then you can gently like sway them. I usually go directly in the direction of the nerve versus not going in the opposite direction, because that's like breaking down a barrier. But the other piece is, for many, myself included, because I had one of these, all those techniques in the world may not be helpful, and some people do have to manage the hidden hernia by removing the nerve compression. And if you're in that population and you choose to go through that surgery, it can change your life immeasurably, because you've never probably realized how much that pain affected you. It's just like, endometriosis. um, Most people who have endometriosis who never had an excision don't realize how much their life changes when they have an excision, because they don't realize how much they're being held back. But the other thing is, if you're dealing with groin pain in someone with endometriosis, especially on the right, you have to also remove the appendix, because so many people, even without it visible at the time of surgery, have groin pain from the appendix. But if you also have the hernia on top of that, then you really have groin pain. And so you play this game of like, well, what do I do first? So like most of the time we have people like, if you have endometriosis and you have um, one of these hidden hernias, we do the excision first, and then we see, because if you take down all the inflammation from the endometriosis, maybe I have techniques direct to the ilioinguinal nerve itself, that's like a myofascial, like strumming almost, but it's not really strumming because it's not aggressive, where you're working along the nerve on somebody's abdomen. The other thing is, it can be very helpful if you dry needle. You may be able to dry needle that area. You may be able also to manage it. I work with people who sometimes can do not necessarily a steroid injection, but they do a Traumeel injection, which is a herbal anti-inflammatory, directly into the nerve as well. And that may be enough without having surgery. But if your patients choose to have those nerve injections, they should see you like within the next 24 hours, because then you can really go to town on the spine, the hip, the sacrum, and I really believe even the foot, because if you're really prone
Pronating.
and
Yeah.
everything with your ankles, then you're pulling at your pelvis to ruin your adductors so much.
I cannot believe how much we don't look at the feet with the pelvis. It is astronomical how, I mean, it's not astronomical, that's not the right word, but it's just astonishing how little we look at the feet, or at least what I've seen in my experience in the pelvic health community is just only focusing just on the pelvis. Like it's treating the area, like you said, just kind of locally. The way I explain it is, we treat locally, treat the pain, treat the source of the pain, but then you treat the why. Is it the foot pronating that's making it worse? Is it that we're not getting thoracic rotation because maybe we're not pushing off during gait because we're walking in a different pattern? Maybe we altered our gait because of an injury 5 years ago or something along those lines. Is all of this trickling up? And thoracic rotation is one of the most missed things that I see in pelvic health, because if we're not getting that thoracic rotation, a lot of times it's because we're rigid, we're in this fight or flight, we're trying to run as fast as we can to go somewhere, and we're just go 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 go. We're not breathing through our diaphragm, which then
Well,
affects our lymphatic system. Now add lymphatic system to the pelvis, now add on constipation. Now you've got a cluster of shit all hanging out there.
Well, think about the diaphragm in a number of ways, especially with our pelvic pain population. First of all, our pelvic pain peeps oftentimes are hunched over a little bit, or they're guarding their pain. And their muscle they're going to guard with, unfortunately, is their diaphragm. They're going to use their diaphragm as a postural muscle. And then it's not going to work the way it should, which is going to change thoracic rotation. But Mary, think about something else. When they do surgery on you, suppose that somebody's had multiple surgeries, um, when you have anesthesia, it changes the way the diaphragm works because it has to, right? But for endometriosis surgery, they tip you back because they have to insulfate the belly with gas so that the organs fall away from the abdominal wall and such so that they can really search for endometriosis.
So they tilt back like their pelvis is up and then they're up
Right.
and back.
Right.
And
Now,
okay.
if they're doing specifically, which I was going to get to in the next sentence, if they're doing specifically diaphragmatic endometriosis, they tip you the other way because then right. Okay. But hold please on the diaphragmatic endometriosis. When they tip you back, in many patients, that's going to change the way our excursion is when we wake up from, things that you need physical therapy for. That's going to change thoracic mobility. Then, when you have surgery, you don't like to take a deep breath in or turn side to side because it hurts like hell. And that changes the way your brain connects to your thoracic spine. So you're missing that a little bit. And then the real issue becomes, what about diaphragmatic and lung endometriosis? And how is that fully impacting the system, as well as what is the role of the vagus nerve in all this? So you have all that with thoracic mobility. And then with the foot, I see that all the time because I do groin and hip pain in relation to pelvic pain and endometriosis. And the person goes in to your office and maybe you've gone outside to wash your hands. Like my sink was in another room. So I would go outside to wash my hands. When I came back, the person would already be on the table, usually whether I asked them to or not. And then they're lying down. So a lot of people don't realize that it starts from the ground up. And I need to start the physical therapy session. I got to look at the way your feet are working. I got to look at the way your hips are working. I have to look at how your sternum is moving when you're in standing, and of course your head and neck. And so there, and if you talk about fascial lines, then we really got to talk about the feet and thoracic rotation. So lots of issues. And then I had the privilege of being a non-insurance taker. And so if I wanted to look at somebody's foot, that's no problem because I don't care what the code says. If you are in a big clinic and your code says pelvis, sometimes it's very hard for them to stand up a patient and start working on the foot or the ankle or the calf, right? Lots of fascia in the calf. And I think, we have challenges in the way our medical system is see issue, fix issue when it's not fix issue, it's treat whole person.
Well, I worked in insurance model for 7 years and I still treated like whole body. I would just justify it in the note. And so how much of it is that we're not justifying it in the note? Because and I don't remember having any issues with billing once I justified it in the note and being like, hey, as they do this heel, their lack of push off during gait, so it's limiting their pelvis from rotating, so thoracic spine's being limited. So I also feel like there's a piece of yeah, insurance can say that, but if you're justifying it in the note, why is that an issue? And I was in that for 7 years and I did that.
I think it's gotten a lot dicier.
Has it? I mean, I've been out now 7 years outside
I
of
think
insurance.
look, I am not someone who was rah-rah insurance, but we shot ourselves in the foot as a profession when we allowed an insurance company to determine our worth. And our worth, when we treat the whole person, is that documentation that you're talking about, that you see a change in heel off that's affecting the pelvis and thoracic rotation. We are trained for that. And unfortunately, in many states, and it differs from state to state, the insurance company is dictating what you can do rather than the training that you have. Now, the other thing is how many of our PTs listening are in states where the PT is only doing the eval and the PTA has to execute everything. And I believe that every single day, every single session, you see a pelvic pain, endometriosis, or even groin pain patient. Every session is different because there's an element of eval for everything. But that's because I'm a PT. And I think a lot of our PTAs are very challenged by that also, that the system is very hard for them.
Well, I think that goes back to, what we were talking about earlier, like looking all the way up the chain is, well, why are we so separated? I feel like our industry needs to step up. I mean, I think it's hard because the industry is dictating, right? So then if you're coming out as a new grad and you're told, hey, only treat the pelvis, you're only going to treat the pelvis and you're going to think just like this in this small, narrow lens. Now that affects the quality of physical therapy across the board. What I have seen, even in cash practices here in Austin, that people do internal treatments for the hour, for the whole hour. Can you imagine? No, this is
I mean, I have pelvic pain, endometriosis, and hernias, and I could not do an hour. I mean, I physically could not endure that.
no, they're literally like it's something where it's like a majority of the session is internal. This has been normalized. This is really messed up
I
because
also believe that, and our people out there listening should understand that pelvic PT does not always mean sticking your finger inside someone. That the internal is one tool in the toolbox, but there's 500 things plus in that toolbox, and we're not always doing internal work. And there are people who can't tolerate internal work at all, and we still make
anyway.
tons of progress. And I think the pandemic taught us that because we were treating people virtually.
Well, I've also had it too where people they go in and they're getting treated internally for that whole time, but nobody looked at this tissue, the skin, and it was a dermatological issue.
Yeah.
The pH is
Also, our topic was supposed to be groin pain, but
it goes together. It goes together.
right. I find that in the missed hernia realm because people think that anything vulvar is pudendal. It's all vulvar,
Yeah.
pudendal, and they don't realize. And I used to take out, I used to map the nerve, right? And there's a portion of the labia that's ilioinguinal. And that what's the portion of the pubic bone that's genital femoral. And people don't realize, like, first of all, they think they itch, it has to be yeast. No, if you sit on your foot for a long time and your foot falls asleep, the pins and needles can be interpreted as itching. So if you have a nerve compression in your pelvis, that's the itching. So stop taking the yeast infection medication unless you swab for it each time, because that's an indication that there's a nerve issue. Also, when they say burning, I'm like, yeah, that's not your urine. I mean, unless they have an active infection. But after ruling that out, that a lot of times is a nerve issue. And then, like, it's not all pudendal. And we, of course, could have a conversation of just because a script 15 years ago said pudendal neuralgia because the doctor didn't know what to write on the script does not mean you have to live your life in the box that you could only have this one thing. And that's what I see with the people with endometriosis is you have endometriosis. You've had a horrendous time being diagnosed with endometriosis, but endometriosis also comes with like 18 other things. And we can't only think of you as a person with endometriosis. We have to think of you as a whole person who needs all those things attended to. From mental health to diet to pelvic and occupational physical therapy, we have to start treating you and treating everything instead of you just going because I have endometriosis. Because, like, your lower quadrant pain may not even be related to your endometriosis, and you don't have to have that pain and groin pain to move forward in your life.
Well, I also think that you just tapped on something. It's like the language that we're using with patients, because, oh my gosh, the amount of stuff that we have to be so careful when we're talking about people's bodies because I just had somebody the other day come in, their practitioner told them they have a spine of an 80-year-old, and so then people hold that in their head forever,
Well,
forever.
Psycho Sure has a whole lecture on that. We did it at the Endo Summit, but we call it words matter. But
Yeah.
another thing I hate is people go to me, "Oh, I had an MRI. You should see what my spine showed on MRI." I mean, I don't want to say it like totally, but I don't really give a fuck what the MRI showed. If you're going to, oh, I have a bulging disc. Like a bulging disc is another box for you to go sit in because I would say 80% of the time that bulging disc is not the stop point for your issues. And also, we know now the things that you see in that MRI tube in regards to your spine. I'm not talking about everywhere else, I'm just talking about the spine. Don't necessarily, they're not such a big component of your pain. Oh, I'm bone on bone. Guess what? I'm bone on bone, L5, S1. I don't have any back pain because I have great mobility of the rest of my spine. I make sure I'm strong in my core. And core, by the way, also includes the diaphragm. It also includes, in some ways, the ribs and the scalenes, right? It's not, and I think we're, especially when you have complex issues, you're pushed so far that any little information that you get becomes something to grab onto. And we don't want you to only define what's going on by that.
Well, I think, if we're talking to practitioners and you hear patients saying, well, I have endo or I have this, or like identifying with it, that is a yellow flag to help that patient maybe reframe also how they're speaking, because then you're limiting yourself from everything. I know that I've had it where before I was diagnosed with endo and I was going through all these different things about chronic fatigue and nobody knew what was going on. And, like you said, endo comes with a bunch of other diagnoses, which you're already thinking you're crazy because you've got all these other things going on too. And in that, just being aware of when I stayed in the victim mentality of, oh no, I can't do these things because I'm in pain, or like I have this disease or I have this, then you limit the rest of your life and it almost perpetuates the chronic pain because then your nervous system is on more high alert because you're not doing anything, but you're dwelling on the pain itself. So there's this balance between recognizing and respecting, hey, I have this, but also I am a human and it's not my identity.
Right. I also think like diagnosis, like you were saying, depending on how it's presented to the person, right, can be very empowering. So, for example, I have POTS. And so for years, I wanted to know why my heart rate was high. Am I just like a fatty on the tennis court because my heart rate is so high? Yet I'm pretty well trained cardiovascularly. And knowing that I had POTS was not like, okay, this is why I can't achieve. I have POTS. It was, this is why I have to hydrate the night before. This is why I need salt in the water. And this is why it's okay to say to the person next to me, we're going to bounce that ball a lot between points because I have to let my heart rate drop. And so there's a way when you're a medical practitioner to present diagnosis that's empowering. And then there's a way that presents it where it's traumatic for your central nervous system. And it'll be interesting to see how, as we move forward with lots of work on our central nervous system and work in the research on that, how that may change.
Yeah, it's really hard when somebody's so connected to their diagnosis because you are not your diagnosis. It's a part of you, and it's interesting too. It's like I had a really bad spell of POTS when I was 18 after mono, and that's kind of when everything kind of.
Too.
Yours was too?
Yeah, that's what triggered it all.
Yeah, I could hardly get out of bed for a year in my first year of college, or like that last 9 months of college. Didn't know what was going on. I was told to just push myself harder, so I tried to exercise and I'd flare up, developed what is it? Post-exertional malaise. Was told that I was crazy, basically, and it's not until, like, the last couple years I was like, "Oh my god, I had POTS," and I think it's still, like, lingering. It's not to the degree that it was, but it's
Right.
fascinating to
But I also how endometriosis interplays with the nerves and the veins and the arteries in your pelvis. And in my case, that was very, very significant. We didn't know that until I was 35, but that changed a lot on how my pelvis worked. And I think the role of that, and if you have frozen pelvis, we really can't tell if it's just a venous issue or if the venous issue actually has an obstructive nature from the frozen pelvis. But it's so interesting that an insult like mono might be the trigger for so many people because these things are there our whole lives, but then I think they get triggered. Like
well, if you think about it.
endometriosis is laid down when you're in utero and then becomes hormonally reactive. If I went through my history, for sure I had it in my teens. And then, like, the doctor minimizes you until you normalize it. And then you end up like being so ill that you have 9 million other disorders. I think that's usually what happens with endometriosis.
This is the first time I've like, I mean, it makes sense why POTS and endo would go together. I don't know why I hadn't.
Yeah, we have to explore that more at the Endometriosis Summit. We had Dr. Brooke Spencer this year. We're looking
Yeah.
towards having her next year as well. And I think um we don't really blood volumes changed in someone with POTS also. And I don't know, correlation is not causation, and we all know that. But is it that the frozen pelvis is making a bad situation worse? And how about for those of us with diaphragmatic endometriosis, that for sure is changing your venous system. And I think it makes a bad situation worse rather than it's a huge component of it. Now, can we say, like, what is the role of connective tissue and fascia in general? I don't think we just don't know yet. We're just not there.
Fascia is just so evolving. I mean, the more I'm like trying to stay on top of it, it's just they're finding new cells now and it's just interacting so much differently than we thought even just years ago. And so I think I'm excited for, you and I were talking, I'm going to the fascia conference, but diving more into fascia and just staying on top of the research with it because if your fascia is restricted, then your lymphatic system is going to be restricted, and then you're going to get more compression in your pelvis. And then when you get more compression in your pelvis, that can put more pressure on the nerves. Add on constipation on top of this, right? You've got all of these different things. So it's so multifaceted. It's not like just nervous system. Well, okay, yeah, just nervous system, but now the nervous system interacts with fascia. It's going to restrict the fascia. Now the lymph can't flow. But if your nervous system is restricted, then your peristalsis and your gut's going to slow down. So it's just like, you know,
Now we have to think about what's going on inside the gut and
yeah,
what the role of the microbiome and the immune component in the microbiome as well.
there's just a lot to think about. But I
And I
think,
think, like, so endometriosis is a surgical disease. I don't care what anyone says. You want to try using birth control to modulate symptoms, fine, go ahead. But you should know it's a surgical disease. So while it's a surgical disease, all these other things are not necessarily a surgical disease. And you may never get to that point on the road where you feel amazing and awesome if we don't start to take each layer down individually, because just treating one piece and not treating the fascia, not treating the pelvic floor, not treating the hernia if you need to, not restoring mobility to the spine. Hey, not maybe you need to be really looking at those feet. Like, not doing all these things is not, you may have excised the endometriosis, but you're not going to really have the person feel great in where they are on their journey.
well, yeah, because if their pelvic floor and their fascia is restricted from the chronic pain, you remove the endo and they still have pain. Of course, they're still going to have pain because,
Too many just go back for more surgery.
yeah, well, that's my question then too. Is you're saying, well, hey, it's a surgical disease, but also at what point will you just keep going in for surgery over and over? I mean, there's that too, because
First of all, I typically only work with excision. I don't do, and this is a whole podcast in itself, but ablation for endometriosis, where they burn off the top of the disease and leave the rest of the disease behind, is ineffective. And so, if you've had an excision where you've taken the disease out at its root, can it recur? Yes, recurrence rates are lower, but it can recur. But once you've done that good excision, it's time to start unlayering the onion, as we talk about, instead of like, I have excision, I have pain. I'll do more excision. And because that it can't be a never ending cycle. So like, I have excision, but I still have ovary pain, right? Even though I don't usually think that's your ovary. It's always the nerve. And it doesn't mean like, so your second excision, go in and take out the ovary. It means like, spend some time to do some of these things that we're talking about. Are there people that need to go back for surgery? Yes. Is it something you should be doing every 2 years? Probably not. Probably not. Does it happen? Yes. I totally have patients that do everything they can. And I think that's where this concept that there may be different phenotypes of endometriosis, that's where we really need better research to explore that.
well, if somebody hasn't heard of the endometriosis and the diaphragm, can you explain that? Because not everybody that's listening is super familiar with endo. I did do a podcast with Heather, so we did talk about excision versus ablation.
Now, you and I know her by her first name, but Heather Guidone is really
Oh,
the
yeah.
grandam of all things endometriosis. And she's part of the Center for Endometriosis Care in Atlanta. But diaphragmatic endometriosis, first of all, I'm sure in that podcast you discussed that endometriosis doesn't spread. Endometriosis is laid down when you're in utero and then becomes reactive. So you can get endometriosis on the what I call the diaphragm side of the diaphragm, as well as diaphragmatic endometriosis on the lung side and in the lung. And by the way, I don't think it's particularly rare. There's a great organization by Wendy Bingham, who is a PT, extra pelvic, not rare. Lung and diaphragmatic endometriosis are not rare at all, and they're very misdiagnosed because even with the advanced imaging techniques of pelvic mapping, they are not easily seeable on all scans and or any scans. And most decent excisionists will, when they go in to do a laparoscopy, they will immediately go and check the diaphragm. That's how common endometriosis is on the diaphragm, and also how common it is missed. It's missed so often that now we have to build it into the surgical plan automatically.
Well, what do they do if it's
Lung
on
is
the
different.
lungs, though?
If it's on the lungs, and I would refer you um, to Heather's pretty good with this, or Wendy Bingham, pretty good with this. If it's on the lungs, they do a VAT where they're putting a different hole into the side of your rib cage and going into your lung. They deflate one lung and they take the endometriosis off during surgery. Yes, we do. Dr. Vidali does that. Dr. Cernovo is known for that. There's lots of doctors doing that for lung endometriosis. Now, I had good story. I had some suspected lung endometriosis, and at that time, this is at least more than 12 years ago, I chose to leave it because the techniques weren't advanced enough that the doctor, the thoracic surgeon doing it, couldn't guarantee me I wasn't going to experience a collapse just from having the surgery when I worked out. But the techniques have advanced a lot more. And it's that particular surgery is something that there are a lot better results with now.
But that one would probably almost be like a last resort, right?
I don't think so. We have great diaphragmatic and lung endometriosis videos on the Endometriosis Summit YouTube, really in depth, if you want to learn about them. But if you're somebody who has a history of lung collapse, particularly during menstruation, but it doesn't have to be during menstruation, shortness of breath, difficulty taking a deep breath, and there is any correlation with your period, it's definitely worth being worked up for lung endometriosis. And my experience is that people who are symptomatic from the lung endometriosis, unfortunately, I could never make that great a headway as a physical therapist. It is something that people do have to go through the VATS if they're really symptomatic from it.
Hmm.
I now
That's
then afterwards, there's a lot of work to the rib cage, and there's a lot of work to the sternum, and there's a lot of manual work, and there's all these exercises I do with a sheet, and then yes, there's a role for PT in lung endometriosis, but if you're truly symptomatic, I never made any headway with any physical therapy or by sending. I used to have a great acupuncturist who I would send people to. Also, he never made any headway, and the lung endometriosis crowd, we try to refer through to VATS to somebody that's doing it all the time. You don't want that guy who's like, well, I could try.
it
Yeah.
sounds good. Yeah. Well, I just think of are you all working to get this information into physical therapy schools and
I
medical
mean, I
schools?
saw wonderful, amazing. I see Shannon Cohn, who is, of course, the producer and director of Below the Belt. And I see that she has connected with the APTA, and she's doing a showing of Below the Belt, which Below the Belt is this groundbreaking film on endometriosis that has really become an amazing talking point and educational tool. And so I see her broadcasting to the APTA, and I think that that's amazing. I own the Endometriosis Summit, and we are 3 days of endometriosis education for surgeons, patients, physical therapists, caregivers, and any practitioners. We have a lot of mental health providers also. And we did offer PT CEU this year. And we work hard. I mean, you're probably the same way. Like you call me, I come, and I've done many a lecture in PT schools, especially by Zoom. And I think there's a lot of reasons why now is the time for change, because a lot of change no longer is going to come through the federal government, but change is going to come from the people themselves and maybe from independent funding. But you we have to keep working at it.
Well,
And
so many people that have endo don't know they have endo. Like that's the thing too, is that's a whole nother animal, you know?
you should have there's a radiologist who started her own radiological society just for endometriosis diagnosis, Wendy Van Buren. She would be a great guest to talk about that. But the other thing is there's also silent endometriosis. You can have no symptoms. I don't believe it's no symptoms. I just believe no one is
Correlating.
really correlating and listening to the way your symptoms are. Like so endometriosis causes a ton of bladder symptoms. And I hate when somebody gets on the phone with me for a consult and they're like, yeah, I had like 3 years of infertility, and then I've had a miscarriage and I can't get any eggs out. And my first question is, and what are do you go to the bathroom a lot? And she's like, oh, but I drink a lot of water. I do not want to hear that your urgency and your frequency is because you're drinking a lot of water, because if you're having all these fertility issues and then you're telling me about urgency and frequency, that goes together. Or like or you'll say like, "Are you bloated?" And, "Oh, only if I am not being perfect about my diet." By the way, you shouldn't have to be perfect. I mean, don't sit around with drinking Diet Cokes and eating Twizzlers, but you shouldn't have to be perfect with your diet not to have painful bloating.
Well, no, I think that's the
Bloating is
thing
a
too
huge
is,
symptom of endometriosis.
well, you can easily, and this is something I've done, I've just shamed myself when my periods are bad because oh man, I shouldn't have eaten that cupcake. It's like everybody else can eat a cupcake and they're fine, and they're not having these symptoms. But I think the thing that frustrates me is there's just, even in Texas, is, people can get imaging and then, okay, so then they go in for a laparoscopy, but I have so many people. It's like, well, where do we send them? I mean,
Also, imaging is notoriously inaccurate for
yeah,
endometriosis. I know there are a lot of advances in pelvic mapping and imaging, and the other thing is laparoscopy. You could have no idea what you're really looking for. And
yeah,
I see people every week that have had negative laparoscopies, and then if our clinic cuts them open, they have a ton of endometriosis. So like that's where, first of all, podcasts like this, where you let people be honest, matters. But that's where people like Heather and people like myself and people like Shannon and the advocates who are using their voices to go direct to the people. Nancy Peterson, Kate Boyce of Endo Girls blog, Jenna Reich, these are people who are using their voices on big platforms to go direct to the I don't want to say consumer, direct to the person, because we can't rely on the MD, right? They're busy telling us to lose weight, or did we try going gluten free? And or
dairy free,
want to sell
dairy
us
free.
IVF, and maybe you don't even need the IVF. Maybe you just need the endometriosis fully excised.
Well,
And we have to do a better job at getting out there, and then the support will come from one day from everybody. That's like the Endometriosis Summit. That's its cornerstone, is like, we can't wait for you to educate us. We're going to do it ourselves.
Well, my biggest thing is I feel like, for the people, like, yes, if we're talking to healthcare practitioners and movement professionals here, but in general, people need to understand their bodies. So the more the people can educate themselves. So, I'll tell my patients, I'll show them, hey, this is likely what's happening. Your pelvis moves this way. This is what your lymphatic system does. So instead of just telling people what to do, we need to be educating them on why these things potentially are happening. So then they can start going down their own rabbit hole and starting to do their research. And I really think AI is actually going to help with this too, because people are going to start putting their symptoms into Chat GPT and being like, what is this? And then with all the stuff you're popping out, and I'm not saying everybody needs to go to
Right.
Chat.
But then here's the thing. My friend has 9,000,001 symptoms plus endometriosis. So she puts the
Exactly.
symptoms into Chat GPT, and she also has Sally at her disposal, right? So I'm like, what about this? And what about this? And I serve at this time during my consultations as a sleuth, like a chronic disease sleuth, sort of. And what she learned from TikTok was that she shouldn't go into the doctor and say, "Hey, do you think I have Hashimoto's, or do you think I have POTS?" But she should go into the doctor and pretend that she knows nothing about what's wrong with her and she never heard of ChatGPT in the first place. And lo and behold, 10 doctor's appointments of not being heard, but the one she goes into and she's like, "Oh, how does the thyroid work? Oh, does that make you tired?" Like, she doesn't know all that. Meanwhile, she's head of a medical marketing company. She's not a stupid person, but like, you have to sort of, like, fake it and pretend like you're not this active, engaged patient. That's the appointment she actually got help in, and that still exists in many ways. It is slowly changing in women's healthcare, but, like, I personally feel like women's health, I've talked to people in the last week, they have to bring their husband or nobody listens to them. Like,
Yeah. I mean,
it's
yeah.
2025. We
Yep.
should And it shouldn't still be like that,
But it is. It
But
is.
it
And
is.
so it's like, okay. And I'm not saying ChatGPT is the only AI. I just think as AI starts evolving, especially with imaging and things like that, I'm just really interested to see where all of this is headed.
Well, I'm interested to see, there are some doctors working with AI diagnosis of imaging and endometriosis,
Mhm.
and also of the hidden hernias, which is how we started here. And they're taking like thousands of MRIs that are properly read by specialists, by people who know how to pelvic map, and plug them into these programs to get better maps, particularly for surgery. And I'm interested to see what the next 10 years of that is, because a radiologist there's no fault to them. They can only look for what they're trained to look for. And are we able to train the AI maybe a little better?
Oh yeah, totally. I think so. And
Crazy.
it's just from understanding those learned language models and how it works. It's just so much, just pump in the data. And it's just going to take so much data for it to start to learn. But yeah, it's gonna be crazy. I mean, I'm looking forward to it. I know everybody's scared of AI. A lot of people are. I'm like, I think it's great, and I think the more
Best psychotherapist I ever had was AI.
I know, I'm like, ChatGPT, are you like my partner now? Do I even need to be dating?
Well,
Just
not ready for an AI boyfriend, but
not to that point.
not cool.
But thank you so much for being on. If people, I'll put the Endometriosis Summit on the podcast here. Is there anywhere else you'd like them to follow you or reach out?
They could find us on Instagram at Endometriosis Summit. And we'd love you to join us in Orlando. I know it's far away, but March 27, 28, 29, 2026. And that is also held virtually. And at theendometriosissummit.com, you can always join the mailing list, and we'll see you there.
Perfect. Well, thank you so much.
Take care.
Thank you so much for listening to my podcast. It would be a huge help if you could subscribe and rate the podcast. It helps us reach more people and make a bigger impact. I would also love it if you could join my email list, which is linked in the caption, for podcast updates, upcoming offers, and events. You can also find me on TikTok, YouTube, and Instagram at drmarypt. Thanks again.